often throughout the forum. Today we're focused on clinician well-being, the state of mental health before and after COVID-19. The mission of the Health Policy Institute of Ohio is to provide the independent and nonpartisan analysis needed to create evidence-informed state health value or state health policy that improves health value. I want to thank our core funders who advance our mission with their contributions to our work. And I'd also like to thank our 2020 Forum Series sponsors for their generous support of our online forum series. Feel free to tweet throughout today's webinar using the hashtag HPIO Forum. We're going to offer opportunities to ask questions later in the webinar. We would ask that you type those questions into the questions box. We're anticipating a large number of attendees today, and we thought that would be the most efficient way to work through a series of questions given our little limited time together. We'll then read your questions to the presenters. There's a growing body of research that indicates that health professionals are facing serious problems related to their mental health and well-being. This includes experiencing relatively high rates of burnout, depression, addiction, and suicide, which has only been made worse by the global pandemic. Earlier this year, the Ohio State University College of Nursing, Fold Health Trust, National Institute for Evidence-Based Practice in Nursing and Healthcare partnered with HPIO to examine these issues. Today's presentations will explore the state of clinician mental health before COVID-19, the impact of the pandemic, and strategies to improve well-being among health professionals, including healthcare clinicians and the public health workforce. A link to this publication, as well as today's presentation slides and other related resources, will be available on our website and can be found by clicking on the Events tab. I'd now like to introduce my colleague, Reem Ali, who is a Vice President at the Health Policy Institute of Ohio and has led our work on clinician well-being. Take it away, Reem.
Thanks, Amy. Good morning, everyone. As Amy mentioned, the Health Policy Institute of Ohio partnered with the Ohio State University College of Nursing, Fold Institute, to create the brief that you see here, which was released in February of this year. Development of the brief was informed by a multi-stakeholder advisory committee made up of representatives from public and private organizations, as well as state and national subject matter experts. This morning, I'm going to share key findings from the brief to provide more context on the state of clinician well-being in Ohio and set the stage for the rest of our speakers today, who will talk about the impacts of the COVID-19 pandemic on clinician well-being. There are three primary key findings from the brief that I'll be discussing. First, it's important that clinician well-being is not viewed in silo, and the bidirectional impacts it has on patient care and safety are recognized. Second, we found that clinicians face serious problems related to their overall health and well-being. I'll review some of the data on this, and you'll hear from the rest of our speakers today on how this has been exacerbated by COVID-19. And finally, I'll share some evidence-informed approaches to improving outcomes for clinicians. I'll start with this first key finding. The graphic you see here outlines the bidirectional relationship between clinician well-being and patient care and safety. This bidirectional relationship is very important to consider, particularly as we think about the heightened patient care and safety concerns clinicians are facing in the midst of this pandemic. The diagram illustrates that improving clinician well-being can have positive impacts on patient care and safety. Poor well-being can impact a clinician's ability to provide high-quality care by increasing medical errors and unsafe prescribing behaviors, decreasing empathy, and compromising patient-centered interactions. By improving clinician well-being, these negative impacts on patient care and safety are mitigated and improved. Conversely, improving patient care and safety can also positively impact clinician well-being by decreasing clinician stress, burnout, and improving the overall functionality of the clinical care team. There are also a number of mediating factors that impact clinician well-being and patient care and safety that you see in the gray box here. Examples of these factors include issues related to stigma, shift length, and HIT use. Racism and discrimination within the healthcare system is an example that cuts across all these mediating factors and can negatively impact both clinician well-being and patient care and safety. A comprehensive approach to improving clinician well-being should account for each of these various factors. The research, as you heard Amy say earlier, is clear that clinicians face increased risk for poor well-being outcomes. Specifically, research shows that clinicians are at a high risk for burnout and emotional exhaustion, leading to depression and other mental health conditions, addiction, and an increased risk for suicide. This figure highlights the potential physical and psychological consequences of clinician burnout. According to the National Academy of Medicine's 2019 report, Taking Action Against Clinician Burnout, between 35 and 54% of U.S. nurses and physicians experience symptoms of burnout. The National Academy of Medicine report also found burnout impacts clinicians early on in their careers, with up to 60% of medical students and residents experiencing burnout. The prevalence of mental health conditions among clinicians, particularly depression, has also been alarmingly high. For example, a series of studies over the past 5 years have found that approximately 39% of pharmacy residents reported having moderate to severe depressive symptoms. 50% of female physicians believed they met the criteria for mental illness and did not seek treatment. And nurses were found to experience symptoms of depression at almost twice the rate of individuals in other professions. This data is particularly concerning given that untreated or inadequately treated mental health conditions significantly increase the risk of suicide among clinicians. Data regarding the prevalence of addiction and substance use disorders among clinicians is limited. However, several studies have highlighted alcohol use as a significant problem among both clinicians and health professional students. This data from the State Medical Board of Ohio shows that impairment due to drugs, alcohol, or other substances was the top reason for disciplinary action among active licensees, accounting for 27% of disciplinary actions among active licensees in 2019. And finally, we come to the issues surrounding clinician suicide. As you see here, suicide is really a tip of the iceberg indicator of the poor overall health and well-being of clinicians, signaling the many challenges below the surface that clinicians face. HPIO analyzed data from the Centers for Disease Control and Prevention's National Occupational Mortality Surveillance System and found that suicide deaths were more common among nurses, pharmacists, and physicians as compared to all U.S. workers of the same race and sex cohort. The gravity of this and other data I shared regarding the state of clinician well-being is incredibly concerning. But as you'll hear from our other speakers today, what is even more concerning is that COVID-19 has only exacerbated the challenges that clinicians in our state are facing. The upside, if there is an upside to any of this, is that there are evidence-informed policies and practices that can be put in place to improve clinician well-being. Doing this requires a comprehensive approach that includes providing clinicians with a continuum of prevention, treatment, and recovery supports. This means both preventing factors contributing to poor well-being, such as burnout, in addition to providing adequate treatment and recovery services for clinicians with mental health conditions or clinicians who are combating addiction. An in-depth literature review, as well as input from subject matter experts and advisory group members, informed the development of these 3 evidence-informed approaches to improve clinician well-being. I'm going to review and provide examples of strategies that fall into each of these approaches. Developing and maintaining a positive organizational culture within healthcare and academic institutions, as well as the clinical practice environment, plays a very important role in preventing burnout and improving well-being. Here, you see examples of strategies that can be implemented to advance an organizational culture that supports wellness. This includes appointing a chief wellness officer and supporting strategies like educational pipeline and student loan repayment programs to increase workforce diversity, and implementing cultural competency and implicit bias trainings to combat racism and other forms of discrimination clinicians and patients of color face in the healthcare setting. Implementing evidence-based wellness programs can also help in reducing burnout and fostering resiliency among clinicians as well as health professional students. This includes cognitive behavioral therapy skills building, peer support, meaningful recognition, and compassion programs. Another area of focus is providing confidential mental health and addiction screening, referral, and treatment services, and combating stigma clinicians may face in seeking treatment. This includes developing a confidential treatment and monitoring program as an alternative to disciplinary action by health professional licensing boards for clinicians who have a mental health condition or substance use disorder, limiting clinician licensure application questions regarding mental health conditions and substance use to inquiries only about current impairment versus past history of mental illness or substance use, and also exploring an independent organization to oversee clinician treatment and monitoring. And then finally, in order to ensure we are adequately addressing clinician well-being, data tracking and reporting is necessary. There is not a national or statewide repository for tracking data on clinician well-being. Creating a uniform mechanism that allows for monitoring and public reporting of clinician wellness and related measures would help to inform both current and future efforts to improve clinician well-being. There is additional information on the data I shared and the strategies I highlighted in the call to action brief, so I do encourage you to give that a read if you haven't already. We have very much appreciated the opportunity to work in partnership with Dean Melnick, who is Vice President for Health Promotion and Chief Wellness Officer at The Ohio State University. She's also Dean and Professor at the College of Nursing and Executive Director of the Fold Institute. And we very much enjoyed working with her to put a spotlight on clinician well-being. And with that, I'll turn it over to Dean Melnick, who will talk more about the impacts of this pandemic on clinicians.
Thank you, Reem. I am delighted to be here this morning to talk about a topic that I really believe requires urgent action. I left sunny Arizona about 9 years ago to come to Ohio State as our first chief wellness officer. And it has been an amazing, impactful journey. We have shown such fabulous outcomes as a result of Ohio State's resource investment in wellness. So I want to just build upon what Reem pointed out a little bit. Even before the pandemic struck, the National Academy of Medicine said we have a public health epidemic of clinician burnout, depression, and suicide. As a result, they launched the Action Collaborative on clinician well-being and resilience. And I have the privilege of being one of about 62 leaders in our country serving on this Action Collaborative, developing evidence-based solutions to remedy these problems. I also want to point out that my team conducted a national study, a couple national studies actually, prior to the pandemic beginning. We surveyed nearly 1,800 nurses from 19 healthcare systems across the country. We found more than 50% reported that they were in poor physical or mental health. Their health was influenced by the organizational cultural support for wellness. Their health was also affected by shift length. So the longer the shift length, particularly 12-hour shifts, the poorer their health and the more medical errors that they made. Our study was the first to show their perception of wellness support by their institution did have an effect on both their physical and their mental health. Right before the pandemic, we repeated that national study with critical care nurses across the United States and found even higher rates of mental health problems, with 40% reporting depression and over 50% reporting anxiety. This study again showed the poorer the mental and physical health of the nurses, the more medical errors that they made. I published in the journal I edit this past February the first longitudinal analysis of nurse suicide in the United States, which showed nurses are at greater risk of suicide than the general population. And very importantly, job problems and history of mental health issues were associated with risks of suicide. In a systematic review that was published last year, burnout and mental health concerns affected 30 to 60% of all physicians and residents. Unbalanced schedules and increased administrative work were defined as key factors. So now I'm going to switch to mental health of clinicians during the pandemic. This gives you a good view of what our clinicians have been experiencing during the pandemic, being socially isolated from others as they care for patients with COVID-19 is definitely also a factor. What we've learned from prior pandemics and so far from our COVID-19 pandemic is clinician mental health tends to worsen. So it's already poor to begin with, but with the additional stress of pandemics, we see a rise in trauma and stressor-related disorders, a rise in anxiety disorders, including panic disorder. Depressive disorders rise, along with substance-related disorders, as well as suicide. Psychological distress and coping behaviors and preferences for support were just studied among New York healthcare clinicians. Positive screens for psychological symptoms were common. More nurses and advanced practice providers had positive screenings. 57% of these clinicians reported acute stress. Almost 50% reported depression. A third, anxiety. Physical activity was the most common coping behavior used by these clinicians, and they have the most interest in receiving online self-guided counseling. Very sadly, we have started to see the suicides occurring amongst clinicians. William Coddington, a Florida nurse, Daniela Trezzi, an Italian nurse, and then Dr. Laura Breen, who was the director of the emergency department in New York City, died all during now the COVID-19 pandemic due to suicide. I think it's really important to look at the evidence on factors that we know increase the risk of the adverse psychological outcomes now during the pandemic. Individual factors such as clinicians who have a history of mental health disorders or substance misuse, increased time in quarantine, being a nurse and being female are all key factors that place people at risk for poor mental health outcomes. But there are also organizational factors such as perceived lack of organizational support, societal stigma against hospital workers. At the same time, we have evidence that shows what are the protective factors that really do guard clinicians against mental health problems during pandemics. Very importantly, adequate time off work, faith in precautionary measures, supportive peers, and family support. Service and societal factors include PPE provisions, staff faith in infection control practices, clear communication from administration, as well as access to tailored psychological interventions based on the needs of individual staff. So my friend, who is also a chief wellness officer at Stanford, Tate Shanafelt, he did a study with his healthcare professionals immediately following the beginning of the pandemic. And he identified 8 sources of anxiety, including inconsistent access to PPE, clinicians being worried about exposing their family to COVID, no access to rapid testing, uncertainty of organizational support if they get sick, lack of access to child care, support for personal and family needs as work hours and demand increase, the ability to provide competent care if deployed to work with COVID-19 patients, and lack of access to up-to-date information. So we're really in a perfect storm. We know suicide rates are the highest they have been in the United States since 1941. COVID requires spatial distancing to reduce spread. Loneliness is known to be a precipitating factor in some suicide. And changes in suicide risk factors now during the pandemic, including economic stress, increased social isolation, barriers to mental health treatment, anxiety throughout the country being up right now. In fact, the latest studies show 1 out of 3 Americans are suffering from a clinical mental health disorder, as well as an increase in firearm sales. So what can we do? Improving outcomes requires a paradigm shift in our healthcare systems. Our systems have got to use comprehensive approaches that provide a continuum of prevention, treatment, and recovery support. The clinicians who are going to weather COVID-19 the best are going to be clinicians who are practicing in organizations that have invested in wellness resources, developing and sustaining a wellness culture, and providing evidence-based interventions that we know work. We would not send a worker, a construction worker, into a work site without a hard hat? How can we set our clinicians on the front lines of pandemics without fixing some of our healthcare system problems and equipping them with the evidence-based protective interventions that we know work? My team at the National Academy of Medicine and at Ohio State just published a rigorous systematic review. We looked at interventions to improve mental health, well-being, physical health, and lifestyle behaviors in physicians and nurses. These interventions work: mindfulness, cognitive behavior therapy, skills building, gratitude, health coaches, deep breathing on a regular basis. We cannot continue to take 17, 20, 30 years to translate evidence-based interventions that we know work into practice. Because if we don't take a more preventive approach, not only are our clinicians going to suffer, but healthcare quality, safety, and costs will also suffer. I spent the last 25 years of my career developing a manualized cognitive behavioral skills building program for depression, anxiety, and stress. We just adapted that program for clinicians at Ohio State. We call it Mind Body Strong. We conducted a randomized clinical trial. We showed clinicians, new nurse residents in particular, who received this 8-weekly session, 40-minute program, had less depression, anxiety, and stress, and they had higher job satisfaction up to 6 months following the end of the intervention. My dream now is to scale this program to hospitals and healthcare systems all throughout the country. We know CBT works. In CBT, we teach people how they think directly relates to how they feel and how they behave. We teach them to monitor their thinking, to catch their automatic negative thoughts, which all of us have, and to say to themselves, what was just going through my mind? Is this thought really true? Is this thinking helpful? And do I have the evidence to back it up? It is really true that if we can help clinicians change their thinking, we can diminish their mental health symptomatology. This is a table from Tate Shanafeld's article that he just published. These were the requests from his healthcare professionals to their organization during the COVID pandemic. Please hear me, listen, take input, protect me, make sure I have PPE, prepare me, Provide rapid training. The knowledge is critical. Support me in my physical as well as my emotional and psychological needs. And then care for me by providing lodging support and other tangible needs. All of our healthcare systems need to offer mental health screening for clinicians and referral for those who need it. The American Foundation for Suicide Prevention has an encrypted screen for professionals that has the PHQ-9 for depression, the GAD-7 for anxiety built into that. We need to offer these types of screening programs so we pick up the clinicians early on with mild to moderate symptomatology before they get into crisis. Well, right after the pandemic hit, I said to my wellness team across Ohio State, we have to ramp up our programming even more for our faculty, our staff, our clinicians, and our students. So we launched very rapidly an 8-week online series that provided evidence-based tactics and resources to help. I want everybody to know that the sessions were recorded and you have free access to them at this website. We will be launching a part 2 series in August. The other thing that our team at our College of Nursing did, spearheaded by Dr. Sharon Tucker, was to create multiple videos of how do you talk to a colleague who is at mental health risk. Again, these are freely accessible at this particular website. Our Department of Psychiatry and Behavioral Health offers our Stress, Trauma, and Resilience program. It is directly targeted to help professionals as well as survivors with trauma-related disorders. They launched a 24-hour support line for clinicians that is still running during the pandemic. We also launched our OSU Star Best program, which provides brief emotional support team training. The other thing my College of Nursing did was establish a partnership with Trusted Health. They are a staffing organization and career platform for nurses. We received a grant to partner with them. Our nurse practitioner students are actually serving right now as health coaches for 6-week blocks of time to nurses on the front lines of the COVID pandemic. So this is an inspiring message from a clinician who was so thankful for all the support that she was receiving as she takes care of COVID patients. This is an acronym with key evidence-based strategies that I created to help people, including clinicians, to cope with COVID. I hope you will share it with others. If any of you would like follow-up information from me about any of the issues I discussed, please feel free to contact me. Thank you.
Thank you, Dean Melnick. Thank you for sharing all of the research that you've conducted and your colleagues have conducted on this important issue, as well as those additional resources. As I mentioned earlier, the slides from today will be posted on our website, so you'll be able to review all of this information in more detail after today's webinar. Another reminder, please enter your questions for any of our speakers today in the questions box. We'll take those towards the end of the webinar, but please enter those as you're thinking of them. I did have a choreographed aerobic routine planned as an exercise break right now, but in the interest of time, you're all being spared from my choreography. So what I'd like to encourage you all to do, though, I know many of you are working from home, and one of the things that I've found is that it seems more difficult than ever to stay active when you're working from home, because you walk a few feet from your bedroom to your office and a few feet to the kitchen, and you know, all the going back and forth to meetings that you would normally do is now not happening. So we'd like to just encourage you to stand up, maybe roll your shoulders a little bit, stretch a little bit, to keep your mind engaged and your body active and moving. And feel free to stand up throughout the remainder of the presentations. We can't see you. We have no idea what you're doing, so you can continue to exercise even during the rest of the presentations, and that'd be okay as long as you're listening. So I'm now very pleased to welcome Director Lori Chris, who is the director of the Ohio Department of Mental Health and Addiction Services, who will talk about state-level responses to address mental health and well-being of clinicians and those who are serving in the public health workforce amid the pandemic. So hi, Lori. Hi, Director. We're glad to have you.
Hi, Amy. Thanks so much. This is such an important topic. I'm really grateful that you are hosting this and you have such great participation in it as well. So thank you very much, and thanks for inviting us to be here too. All right, I'm not sure I have control of the slides.
See, I'm sure Alana's working on it. I know there's a slight delay.
Okay, that's great. Very good. So again, I'm happy to be here, grateful for the invitation, and really appreciate Dr. Melnick's presentation. I think you'll see my messages echoes what Dr. Melnick talked about, and so I'll jump right into it. I'm still struggling. If you could advance the slide for me. Thanks. So, you know, caring about mental health and wellness is not something that's new to Governor DeWine. This has been a top priority for him for years. And with the Recovery Ohio Council, he really put together a robust team that's working on mental health and addiction issues across the administration. So while our department is focused on it all day, every day with 100% of our constituents, every other department is engaged in many ways too. And Governor DeWine recognized early on in the pandemic that mental health was going to be a significant part of what Ohioans needed to pay attention to as well. If you could advance the slide, please. Thanks. So as we looked at the COVID-19 surge arriving in Ohio, we also knew that there would be a behavioral health surge, and there would be reactions from all of Ohio's population, and certain parts of our population would be more at risk, definitely those on the front lines. But we started seeing very early on distress reactions such as difficulty sleeping, people struggling to feel connected to one another, a decreased sense of safety, or an increased sense of uncertainty that led to a lot of psychological distress. Certainly physical symptoms like headache, skin rashes, stomach aches, those sorts of things as well. And then we started to see people calling in to talk with us about feelings of depression or anxiety, and a lot of grief being experienced by Ohioans, from complex grief, from multiple issues or significant events like the loss of a loved one to COVID-19, or worry about a loved one who's ill, to just loss of normal day-to-day functioning and our movement around the world, or social events even that were planned for and exciting. My daughter, for instance, was graduating from high school this year, and so that looked much different than we expected it to. We certainly moved through the phases of grief with that. And then we've definitely seen an increase in health risk behaviors. We saw alcohol sales surge in March, and we thought, well, that might be like the hoarding of toilet paper and cleaning supplies that everyone's doing. But we've seen that elevated sale of alcohol throughout the pandemic. And so monitoring alcohol use, knowing that people are using alcohol as a coping mechanism, is something that we're paying attention to. We also know that firearm sales increased during that same time period. So just as Dr. Melnick talked about that. And there's a lot of family distress, disruption in daily life, lack of a normal routine. All of these impact how we're all feeling as Ohioans. But you can see that resilience is still the largest circle. And so we're very focused on helping people understand that emotional distress is a normal reaction to this pandemic, that it accompanies all disasters, that each one of us is feeling it in a different way, and that talking about it is actually helpful, and overcoming challenges builds resiliency and prepares us for future challenges as well. Next slide, please. So we set out instantly to build on the work that we already had underway and to make it coronavirus specific, and really made an effort to make help for mental health and addiction issues more visible, improve opportunities for people to understand what the signs and symptoms of mental health and addiction issues are, to make it normal to talk about mental health and addiction, and so end that stigma, improve opportunities for financing, and ensure access to resources. Next slide, please. Some of the things we did specifically were work with the Department of Medicaid to update our rules on telehealth for continued access to care. And that was for those clients who were already engaged in services, or for someone who was identifying the need for services for the first time. So we expanded telehealth rather immediately, announcing that in March, making it easier for citizens across the state to access care remotely from their homes, whether or not they had the technology to do it, and whether or not the behavioral health providers had the technology needed as well. We made it okay for text and cell phone use, for landlines to be used, because so much of Ohio doesn't have access to broadband services, and because technology can be overwhelming, and so we wanted people to quickly access care. We pursued wellness campaigns and social media campaigns promoting wellness, reminding everyone that behavioral health is open to business, to keep your appointments in person or via telehealth, to keep taking medications that were prescribed as prescribed. And we increased access to those prescribed medications, especially for opiate use disorders. We worked with the federal government around those guidelines to expand the capacity for Ohio's providers to be able to prescribe methadone and buprenorphine differently than they'd been allowed to in the past. We also made naloxone more available. We increased the supply, and we made it available by mail order. And so making it very easily accessible for those Ohioans who need access to life-saving medications. We created some easy on-ramps like the COVID care line and the crisis text line. So making sure to market those things. And we saw an increased utilization of those resources that were staffed 24 hours a day, 7 days a week by trained professionals who can engage in a meaningful conversation about what the caller is interested in talking in, and either provide that increased screening or brief intervention or a referral to treatment. And we actually did several active rescues through both of these resources to people who were, in fact, in crisis and needed immediate intervention. Next slide, please. So we've already talked about COVID-19, trauma and stress, and I won't walk through all of that again. Dr. Melnick covered that so beautifully, but we do know that trauma can be a pervasive problem for some groups, especially those in the role of providing care or protectors. So we did some very specific work up front with medical professionals and first responders to make sure that they had trauma-informed care resources and peer support in place. We worked with nursing homes to provide emotional support to the staff there and the leadership there, and to residents and family members when there was an outbreak at a nursing home. Our trauma-informed care team also worked very closely with the boards that regulate Ohio's professionals and with associations. So for instance, we worked with the Nursing Association and APRNs to create a curriculum on how to provide peer support for emotional support to people who are working on the front lines of the pandemic. So those are some examples of things we did early on. Next slide, please. And it's important for us to remember that while we're all in the same storm, we are not all in the same boat. So some of us came to this experience of the pandemic with a lot of what we would call wellness capital or recovery capital. And we had a lot of good things happening in our lives that gave us protective factors for being able to deal with the stress that the pandemic introduced. But many people came into this pandemic without those things, or experiencing a much different storm than perhaps I did. You know, my kids are 18 and 20, so I didn't have to deal with homeschooling and engaging them with their online courses. They were capable of managing that themselves. I was lucky to be able to telework, so I didn't have to be in an environment where I was exposed to the virus in a life-threatening way on a day-to-day basis. But not everybody was in that boat, right? And so being sensitive to that, we need to make sure that we have strategies and recognize each person, where they are, what their experience is. And as Dr. Melnick said, hear that, listen to that, believe that, and then respond to that in appropriate ways. Next slide, please. The signs of distress, if you are a clinician yourself or if you're working with clinicians, there, you know, all of these things may impact any one of us on any given day, but if they are lingering in nature or sustained in nature, that's when any one of us needs to reach out and ask for help outside of ourselves. So a hard time concentrating, increased alcohol use, again, using alcohol on a regular basis as a coping mechanism, a way to calm down, a way to relax, a way to kind of numb out, or any drugs for that matter, is a sign that that is a problematic substance use and not just the one drink a day social substance use that would be recommended, or not recommended, but allowed or seen as not unhealthy. Anybody that's having outbursts of temper, physical reactions, these would all be things where a person should talk to their primary care physician, to their mental health counselor, or to call the COVID care line and to ask for some support. Next slide, please. And I think as health professionals, as people who have dedicated our lives to helping others, we give a lot of ourselves all day, every day, and that takes a tremendous amount of energy. And we're not necessarily programmed or wired to take care of ourselves or to take care of ourselves first. And so it's really important that we all slow down, do things that we know will help us recharge, center, have a really good perspective on our own physical and emotional and mental health, and then we can take care of others better. Next slide, please. So here are some things that managers and administrators can do. Making information available to staff and to families. Families are tremendously traumatized by knowing that their loved one is on the front line in a healthcare setting. And so giving them information to cope, giving the staff member information about how to keep themselves healthy and safe and how to support the health and safety of their family is incredibly important. Creating an environment where it's okay to say, I need a break, or I'm not doing very well today, I need some additional resources, or just some time on the job to do some brief meditation, some breathing exercises, to get some fresh air, to take a walk, to do those things that help decrease our reactivity and increase our sense of control. Regular check-ins and coaching. Management can't be attentive enough to the needs of people on the front lines. And then a debrief at the end of each shift. What went well, what didn't, what can we do better tomorrow to make this a good experience, better experience for you and for the patients you're caring for. And then all of us as healthcare professionals need to take breaks from the media. I learned a new term last week, doom scrolling, so that going through the Twitter feed or the Facebook feed or even checking the news feed and just seeing one story of traumatic or divisive events right now after another can be really negative for us psychologically. So find a trusted source, use it at a in a planned way, and then unplug, step away from media. Take care of our bodies, breathing, eating healthy foods, sleeping, exercising, avoiding alcohol and drugs. Those are all important things. And then connecting with others in positive ways. We started a campaign called Strive for 5, where each one of us can take the pledge to reach out to 5 people each day, whether it's a phone call, a video chat, a text, not somebody necessarily that we're meeting with for a work purpose, but just someone that we want to say hi to. Maybe it's a note that you send someone. Those are all things we can do. They help us and they help the other person. Doesn't take any special skills to say, how you feeling today? Do you need anything? How can I help? And offer resources if someone sounds like they need them. Next slide, please. So again, there are a lot of things in here. I know that Dr. Melnick talked about shift scheduling and hours work to reduce burnout. That is something that the literature we're looking at and sharing in the criteria or the recommendations or the Restart Ohio guidelines are part of this as well. And redistributing workloads as needed. We operate 6 regional psychiatric hospitals and have direct service providers in all of the state of Ohio correctional facilities as well. And so we're not just doing research and putting these out for other people to practice. We have an obligation to practice these ourselves. And so we're doing really working to create that culture of wellness within our own organizations and minding shifts and hours work and caseloads as well. Next slide, please. So here's an example of some of the things that we've done. We have weekly calls with our regional psychiatric hospitals. They're led by our trauma-informed care coordinator, Kim Kale, and he works with a team that's dedicated to supporting the trauma-informed care needs of our patients in our regional hospitals and of our staff. So a mindset of this team that's looking at how people are responding to chronic stress and potentially toxic stress, and creating an environment where it's safe to talk about that and to respond to it. And the calls have brought out a lot of ideas that they're using in all of these settings, including giving people the tools and the resources they need for workplace yoga or mindfulness techniques. And in this Together campaign, where there's the masks, the face shields, the cleaning supplies, the hand sanitizer, the hand washing stations, social distancing to increase that security that each individual has and confidence in the safety of their work environment, but then also signs and messaging and videos that we share so that employees know that they're not on the front lines alone. Many people are there supporting the safe practice that they have. Next slide, please. We're also put out guidance for people working in outpatient settings as well. And again, are using this with our own staff who are out in the field in direct service or to Ohioans. And so helping people remember the things that they need and building the resources and skills that they need to prevent the spread of the illness to themselves or to others, like making sure that they're monitoring their own symptoms, that they have access to masks and cleaning supplies, and that they're following social distancing guidelines. Returning to structure can be really difficult too. We had a number of folks who were teleworking initially and then needed to return to the clinical setting. And so helping get back into that structure of being in that environment, overcoming that anxiety of going back in for the first few shifts, and building that confidence that they were going to be able to be successful in that environment and be safe themselves. And just making it okay to talk about anxiety, get questions asked, get needs met. What I need and what someone else needs might not be the same thing, so trying to make that as individualized an experience as possible. Next slide. Here are some of the toolkits. We have many more available. We also have our social media campaign materials available. You're welcome to grab any of these toolkits, any of the materials, and use them for your own organization. And you can find them on our website, which is listed at the bottom here, mha.ohio.gov/coronavirus. You can see that we are looking not just at clinicians in healthcare settings, but also emergency responders, mental health providers, addiction services providers, and outpatient settings as well. Next slide. Again, I really, really want you to all use the COVID Care Line to share these resources with your networks, 24 hours a day, 7 days a week, professional trained staff available to help with crisis counseling. And that crisis can be anything from I'm feeling mild anxiety to I'm feeling like hurting myself. So it's really the crisis the person's experiencing, that outreach for help. It is confidential, and both the COVID Care Line and the text line, which can be used from anywhere by texting the number 4 and the word HOPE to 741-741. You can talk to a person, or you can text back and forth to get a consult with someone. Next slide. And then just for more information about our organization and all of the resources that we have available to help people access prevention, harm reduction, treatment, and recovery supports can be found at our website, and we urge you to follow us on social media for new developments too. Thank you so much for having me here today.
Thank you, Director Chris. We appreciate your presentation and all of the additional resources that you provided. Once again, a reminder that the presentations from today will be available on our website, so you will be able to go back and review these resources and distribute the appropriate links to colleagues in your networks as well. Next, we welcome Dr. Bryant Adabe. He is the System Vice President and Chief Wellness Officer at Rush University System for Health in Chicago. He's going to talk about creating a culture of wellness, in particular highlighting an initiative that Rush developed to promote wellness in healthcare systems during this pandemic. Welcome. We're happy to have you today. Oh, and we can't hear you.
We can't hear you. Try entering your audio pen.
There we go. Can you hear me now?
Yay, yes.
Look at that. I got the camera and microphone working. All right. Well, thank you so much for the invitation and for the warm welcome. All right. Should have a few slides. Great. All right. Well, as she mentioned, my name is Dr. Bryant Adabe. I either go by Bryant or Dr. A, what most people call me, but really excited to chat with you all here. Been listening to some of the tremendous presenters that have gone before me today. Obviously, I'm very, very familiar with Dr. Melnick's work. Really been a pioneer in this field as a Chief Wellness Officer, and to hear the tremendous work that Dr. Chris is doing on behalf of the state of Illinois, of Ohio, is certainly inspiring, and something that I think our state in Illinois can continue to benefit from. So thank you all again. Why don't we go ahead and jump in? I just have a few few slides I wanted to present as a context, as a case study rather, for some of the work that we have done in Chicago at Rush. And before I get into the specifics, the 4 strategies that we'll outline, I'll start by providing some context of how the pandemic impacted our health system and why it was important for us to to respond. So I think the shortest statistic that'll give you the best understanding is at our peak, at one point, at the peak of the surge, 25%, so 1 out of every 4 critically ill COVID-19 patients in the state of Illinois, in the entire state, were being treated at Rush University Medical Center, which is a pretty staggering 5% of critically ill in the hospital. So that's a long way of saying that we had a tremendously heavy load, and there were some great outlets that reported that Rush was really the bellwether institution for the city of Chicago and for the state as far as how we would respond. And it was something that we just took tremendous pride and excitement in being able to serve our community. As a health system, though, that also meant that we had to be incredibly agile. We had to respond. And as a wellness team, we had to develop a framework for how we would support the well-being of our institution. And one of the great findings that I can remember from the spring and thinking through as we were rounding on one of our ICU units was there was a tremendous sense of calm at Rush, despite the staggering numbers of patients we were helping and treating. So we piloted and developed 4 primary strategies to support and develop the well-being of our community in the midst of the pandemic, and put this all together into a toolkit that's freely available to all hospitals and health systems, and also put this together in a publication, which I'll get to as well. Our first step was to form an interdisciplinary wellness task force. As our institution moved to centralize our response through our central command center, we want to do the same from a well-being standpoint. So if it involved the well-being of the Rush University Health, we wanted it to come through the central interdisciplinary team. From that team, we then created what was known as our WRT, or our Wellness Response Team. Some of the disciplines you can see are listed here. So we had physicians, we had nurses, we had social workers, we certainly had chaplains and psychologists. And the idea behind this was to really create an interdisciplinary group that would serve as the primary workforce for all things wellness and responding to this pandemic. So the first thing that we launched were wellness rounds. And I'll tell you that, rounds, particularly in the midst of the pandemic, were something that a lot of health systems and hospitals did. I think part of what distinguished our approach was the structure, the consistency, and really the training that went into it. So each of these teams, these 5-member teams composed of each of the disciplines that I've listed before, would round on the exact same ICU COVID units every day at the exact same times. And part of what you're seeing here in this photo is an image of myself, our Director of Strategic Initiatives, Eve Positek, to my left there. And to my right is actually our system CEO, Dr. Ranga Krishnan. And we're in our regular team huddles, which happen every day at 2:30, the exact same location and time, in the midst of this pandemic, to create a two-way flow of information and to where insights from the front lines could be rapidly escalated at our huddle up to our command center, and then changes and decisions made in our command center can be rapidly communicated to the front lines. And what this really created was a tremendous amount of feedback that allowed our organization to demonstrate agility and to rapidly respond to issues that our folks were experiencing. And so for all health system leaders and those that are either have gone through or are currently continuing to manage through a surge, I think having that community-based buy-in, decision-making, and trust through this interdisciplinary network was incredibly helpful. Next slide, please. One of the second strategies that we launched was a physical space. So we can think of the wellness rounds as being our daily foray into these units as a chance to really check on the staff, to do what some would call reverse rounding. Instead of rounding on patients, we're rounding on the actual clinicians and ensuring and supporting their well-being. But we also knew there was a need for a space. So we launched an initiative through what we thought of as a hub and spokes model, which was a central wellness resource hub, and then a network of wellness rooms with an emphasis particularly on the COVID floors, particularly the COVID ICUs. So the wellness resource hub can be thought of as a pop-up wellness space. We staffed it with mental health providers, including psychologists and our licensed clinical social workers. What you see there on the picture on the left is about a 12-foot projection of waterfall. There was calming music, healthy free snacks, lounge chairs. It was centrally located within our busiest tower building at RUMC, with the idea that staff could use this as a way to leave the unit, clear their minds, have a moment of respite, of meditation, of mindfulness, and if necessary, to check in and meet with one of the members of the wellness team to talk through any challenges they may be experiencing, including addressing any of their mental health needs. Again, for all the clinicians on the line, for many folks, it is very difficult to leave the unit. And so the picture to the right is one of the wellness rooms that we launched, which were actually on the units themselves. And the idea here was for those that couldn't leave the floors, this is a chance to actually have a quiet space away from a break room, away from others, that they could similarly have that experience of respite. And so this combination created a great network within the hospital that, again, helped further that concept that wellness was a priority. Next slide, please. I mentioned earlier that one of the distinguishing characteristics that we tried to bring in with our framework was really structure and to create a standardized response. And part of that you're seeing here. In the hospital, the idea of calling a consult, a cardiology consult, or a GI consult is a very normal concept. And to further introduce this idea of wellness into the clinical environment, we launched a wellness consult service. And what this allowed groups and individuals to do, those who were battling on the front lines of this pandemic, was to rapidly get in direct contact with the wellness team. As you can see in the graphic at the bottom, individuals could call a wellness consult for themselves. That is, I would really just like to speak to someone and talk through either a patient case that was difficult or personal or other concerns or issues that they may be encountering. They could also call a wellness consult anonymously for a colleague that they might be concerned about, demonstrating some signs of distress. And then we also work with groups. And so what you see here at the bottom is a graphic from our publication on this whole framework that shows you some of the roadmaps that we use. So if this is an individual at work, it's routed one way. If it's about another individual anonymously, it's routed in a different direction. If this person's offsite, we handle that differently. And then if this is about a group, we initiate what's called an SOS, which is a structured a program here at Rush that we have that stands for Support Our Staff. That's a group facilitated discussion. What you see here is this framework that we've provided allowed us to standardize the response. So the advantage of having an interdisciplinary team is that you have great insights from many different backgrounds and you have a tremendous amount of input. One of the challenges is each of us brings our own perspectives. And so in order to ensure that we had consistency and coordination across our wellness response team, having this very clearly articulated pathway was a really key finding that we found to be helpful. And as you'll see on the next slide, it was especially helpful for many of the crises and considerations that Director Chris spoke about previously. Next slide, please. Finally, we know that when we begin to send psychiatrists and psychologists and nurses and chaplains and others onto units to really check on the well-being of our staff, inevitably you will encounter those that are in a more serious circumstance. And so we refer to these as Wellness Plus. We can think of these for the rare but serious. And what we created was a clearly articulated escalation pathway to where if a member of our wellness team while on rounds were to encounter some of the things that have been mentioned so far on this webinar, a staff member indicating, for example, that their coping mechanism was primarily through substances or other risk factors that were red flags, we were able to standardize how our teams managed these kinds of issues through this pathway that we have here. And I know this may look a little small on the screen, but what this does is it gives us a framework for understanding how we should respond to these, including those that may be at risk of self-harm, or as we mentioned, of substance use or otherwise, a very clearly articulated pathway of how to do that. So I'd like to provide a simple example here. In the midst of our surge, we had a unit director pages through the wellness consult service indicate that they had a staff member that they were really concerned about. They were behaving unprofessionally and really adding some stress and pressure to the overall team morale. As a result of that consult, we were able to send a member of the wellness response team to check in on this staff member. They used the wellness rooms that were already created and designated on that unit. And this member of our team then was able to follow the escalation pathway that we have articulated here. And we're able to quickly deem that this person had been off of some really important medications for a while. We escalated this through our Wellness Plus pathway, and within a matter of hours, we're able to get that person seen and taken care of by one of our providers. that had a direct impact, not just on the overall morale of that unit, but the team. And in many cases, we would say prevented potentially some safety, either personal or patient-related events in the future. So that's part of the process that we wanted to create a framework and structure around how to respond in the midst of this pandemic. Next slide. All right, so a few future considerations that we think are important. Number one, so we're a health system, and we have another medical center about an hour, almost an hour and a half outside of Chicago. And so we really wanted to create a threaded system-wide initiative using all four of these pieces. And we've since done that and really had tremendous feedback from our staff about their excitement and eagerness to be a part of this much broader wellness initiative. We also have integrated the work that we're doing now with our new Rush Center for Clinical Wellness, which is now really think of this as the long-term headquarters for all things well-being for the Rush system. And so being able to pair that escalation pathway with an actual physical space where staff can go has been key. We've also really taken a proactive stance in screening all clinicians who are seen in our center for PTSD and other related issues to ensure that the long-term sequelae of this pandemic does not have a negative impact on our staff. Next slide. All right, so in conclusion here, some final recommendations and points for consideration for the audience and those that are here today. Number one is what I've described really as a framework that is focused on an institutional resilience mechanism that ultimately leads to well-being with an emphasis on the actual structure that produces it. And so that's something that I always recommend. So we know well-being is often something that we think of as a state that is subjective in nature and that is often tied to the present. But one of the keys is to really create a framework or a process whereby we can create wellness in an ongoing manner. We also want to, as we know, our nation continues to battle, and our world really to battle this pandemic. We know as we prepare for this cold weather, particularly in states like Illinois and Ohio, that we need to be prepared for a potential second spike or wave. And I think of this when I say the reverse surge is the psychological downstream impact and the impact of a second wave that can have on our staff. So really being prepared for that and being able to support our teams from that disillusionment or the challenge phase to a reconstruction and resilience focused phase. Next slide. All right, so before I conclude, I wanted to say I mentioned that this was a framework. Everything that we've presented here, we put together in much more detail in about a 20 to 30 page toolkit for hospitals or health systems that could benefit from a similar program with pictures and videos to help talk through how to implement something similar, including a granular schedule of how to run wellness rounds with a similar approach. All that's available on rush.edu/wellness, completely free and open to the public there. We also published this work, so if you see the graphics that I talked through, I didn't spend a lot of time on them, but the Wellness Plus escalation pathway, the Wellness Consult Service, all of those were published in a New England Journal of Medicine Catalyst piece that goes into great detail around what we saw, lessons learned, and ways that you can build and improve on this going forward. I wanted to share and make that available, but I'll end there, and thank you all for your time.
Thank you, Dr. Atabey. I think it was the New England Journal of Medicine piece that we saw that led to our invitation to you today. And that's great news about the toolkit. As I mentioned earlier, not only will the presentations be up, but we will provide links on our website to the resources mentioned throughout today's webinar. We do have one question in the question box, and that is, and I think this could be directed to any of our presenters, so perhaps we can ask you all to unmute. But the question is, I'm curious if you can speak to the breakdown of ambulatory versus inpatient healthcare workers. Were there any differences? This may be speaking to Dean Melnick's earlier presentation, but I'll open it up for everyone. And once again, if you have a question, please type it into the question box.
I think that's a very excellent question. Research has been done much more thoroughly with acute care clinicians versus with ambulatory. There are a few studies out there with ambulatory healthcare clinicians, but again, we need so much more data on that subgroup. We did not analyze our national findings by ambulatory versus acute care, but I'm going to go back now and do that. So please feel free to reach out to me in about a month and I'll have the answer for you.
Great, thank you. Thank you very much, Dean Melnick. I don't see any more questions in the question box. I, again, thank all of our presenters. It's always wonderful when we host a forum and we learn from the presenters that we host on that particular day. So thank you for sharing your time and your intellect and wisdom with us. We're going to send out a survey after today's webinar for all of you who participated today to provide us feedback regarding the forum. So please take a few minutes, it'll be brief, to complete that so that we can implement any changes necessary for future online forums. All of the forums for the remainder of 2020 will be online, or I should say all of HPIO's forums for the remainder of 2020 will be online versus face-to-face. We do miss seeing you all face-to-face and being together in person. But we're glad that these technologies are available to us so that we can still continue to learn together, in particular on a topic like today. Not only do we hope that you'll be able to take some of the tools and resources and learnings from today back to your organizations, we hope you picked up 2 or 3 ideas that you can implement even yourself personally to take care of yourself through this pandemic. It's definitely a challenging time for all of us, and I think it'll be challenging for a while. So very important for us to be taking care of ourselves and taking care of each other as we move through the next several months. With that, I will conclude our very first online forum, and thank you again for your participation and engagement. Have a great day.